Good morning. It's a pleasure to be with you today. Being in this Abseneo Congress, we're going to take care of the motor development from birth and follow-up. I had the pleasure to introduce the three main speakers. Licensed in physiotherapy, Ruth Yvonne Reyes Rodriguez, from the University of Mariano Galvez in Guatemala, physiotherapist in neonatology and early care, physiocognitive therapist, and kangaroo mother care physiotherapist, and orofacial in preterm babies. And afterwards, Dr. Licenciada, licensed Luz Vaquero, commissioner. She's director of the therapy service of the Center of the Blind and Deaf in Ministry of Education in Venezuela, certified in sensorial integration, the University of South of California. Active member of the Colombian Association of Sensorial Program and Development of the Newborn Babies in Venezuela, Dr. Alvarado Dalgo Robles, physiotherapist, who pertains to the research group in early care INAP in La Rioja University in early detection of cerebral palsy. He is professor of this university and member of the board of directors of the European Academy, and also the in disability organization, as also in Italian organization. It's a pleasure to introduce the doctors. Thank you very much. Good morning. I would like to welcome you again. I would like to give the floor to licensed Dr. Yvonne, who is going to talk about the process from the ICU until the follow-up and the motor development. Dr. Yvonne, the floor is yours. Good morning. For those who know me, you know what I like to talk about is as follows. Okay. I'm going to control the time here, the timer. Okay. I would like to say that the topic of today is protection of the motor development inside the ICU. And I had prepared what I'm going to talk about now, but yesterday I would like to thank the visit to Bolivariana Clinic to the ICU, and being there, okay, things changed for me. So last night, speaking with my friend Vivi of Fundapre, okay, the overview is also going to be changed. So what I'm going to do next is, if we talk about to a preterm baby, if we interview a preterm baby and we would ask that baby, how do you feel in ICU? Because at the end of the day is what we all seek, his well-being. I think what they would answer to us regarding that question would be not very well. Why are you not feeling comfortable? They would say, because before I had a name. Before I saw that my mother said Javier or Mateo or Rafael. He would call me by my name. But now today they only call about me the newborn of 32 weeks. So I'm confused with that. I'm not very pleased to be called a newborn baby. And on the other hand, he would say, I feel alone, I don't feel okay, because before that I listened to my mother, and now I hear voices of people I don't know, and I feel very isolated and alone. And I'm pretty sure the preterm baby would also answer by saying, many people touch me, and all those, when they touch me, it's painful. They do things that are very painful for me. Because in the past I was at home, in my mother's womb, and I was feeling happy. but they all touch me, and everything they do to me is very painful. That would be the third claim of the preterm baby. Okay, the fourth would be I'm afraid. I'm afraid, really afraid. Somebody approaches me, I'm afraid. Maybe I'm starting to sleep, and when somebody arrives and touches me, all those who touch me do something that really hurts me. When, before I was only with my mom, everything was happiness. And the last thing he would say to me was a lot of noise. There's a lot of noise, there's a lot of light. The problem is that I don't have the capacity to close, to defend from the light. I don't have the capacity to close my eyes and to close my ears, and everything bothers me. And in fact, everything affects the development of a baby. So, what are the strategies that are out there and that we propose is precisely uh, to helping dads follow up in the preterm baby. First of all, is the participation of the family. If your mother, father was the surrounding, was the people who he knew, has to come back to the unit, has to accompany the baby. It's a critically ill baby, immature, and maybe arrives to a different place and he feels alone. So one of the first recommendations that are being told is focused on development of the family as a neuroprotection measure is that the baby should be accompanied. His family should be with him. The family is not a visit in the ICU. It's part of the team of support and treatment of the baby. Do you remember when we took the friend or our boyfriend home? I want to get to know the family.
Only friends, and I remember that they said, I want to know what hen laid that egg. And the same thing, it's the same thing. The premature, it's not on its own. The premature has a family, has an environment, and we need to know, and they should participate in this care process. But what does the evidence recommend? That we need train, and because he is prepared to be a baby, but not to be prepared to be the dad of a critically ill baby. And that's why, as a neuroprotection measure, what we need to do is to prepare the family, to train the mother, to train the father. What are you going to find in this unit so that he is ready? And the second tool, it's the kangaroo mother program. It's the mother kangaroo program, because this is going to give us all the comfort, all that link, and it's going to help the mother to be empowered and to treat. mm, We can see that a baby that it's been managed through the kangaroo program. And the third complaint of the premature was it hurts. It hurts. Everybody's hurting by me. Everything that they do hurts. What does the evidence tell us? That the premature baby receives 5 to 10 painful interventions per day. And the ones that are the sickest are going to receive between 10 and 20 a day. What can we do as a team? What can we do as part of the team that is part of this baby? And that's why we have the the non-pharmacological analgesia, and the non-pharmacological analgesia tell us that we need to we use whatever we can so that this baby doesn't endure pain, because at the end we do know that that the pain, that the long exposure to pain, it's going to affect their cognitive development and their future development. We can see that the NICU helps to save lives, but it also brings a lot of issues. And we can see that much of the damage that's caused in the ICU, it's something that we're not going to see this right now. But they are going to be, we're going to see them in the future. And that's why parts of the non-pharmacological, the contention, and the kangaroo mother, neonatal massage, all this series of tools that we have to help this baby. And the second one, remember that the baby gets scared. The baby gets scared when he's in neonatal unit. Everybody gets close. Everybody possibly. I'm falling asleep, and then so they come in and they touch me, and the therapist comes and the physiotherapist comes, and now it's the time to, and they move, and once again I was falling asleep. We can see that there it's a dialogue amongst the team. We needed to learn how to coordinate all the types of interventions that we're going to use in this baby, and the positioning, which is basic, because the physiotherapist, it's the guardian of the positioning of this baby. We know that she has to be within a contention, the nest contained flags, the comfort. I always tell my students, how would you feel? How would you feel if somebody goes and you have no capacity to move, and after an hour you're still there, you're uncomfortable, and you can't move, and maybe the nurse that moving you leaves, and that there's nobody to move you around, and therefore what do you do? What do you do as a patient? They start late to tell you, know that I'm not well, and this would be the complaint. And the other thing to remember, what they was saying, there's a lot of noise, and there is a lot of noise, there's a lot of light. And when I was before, when I was inside my mother's belly, I couldn't hear anything because all the noises were pleasant. I could listen to my mother's voice that was humming. She didn't have to protect me, and now she does. And now there's no one that protects me from this. And that's why when we need to learn that we need to take into account the macro and the micro and environment, and the macro environment tell us this: lights and sounds. The evidence tells us that the human voice has between 50 and 60 decibels. And however, the evidence is telling us that if I want to protect this baby, I should expose him to a noise that is below 50 decibels. So what must I say that the neonatal unit, we we talk. Everybody needs to lower their voice, and when we have the big prematures, it has to be even has to be below 30. There shouldn't be any noise where a premature is. The same thing happens with the light. When there's a big premature, the light has to be between 1 and 60 lux. And the big prematures, or the ones that are less than 30 weeks, less than 30 lux. I remember that once they called me to the Social Insurance of Guatemala. They called me, and when one initiates a specialty, because I'm the pioneer in Guatemala, so they invite me, to test me, as a way to test me. And I go into the neonatal unit, and they say, okay, go this way. Do your first intervention. Take care, because this baby, it's 38 weeks now, but we are not able to regulate her, and they start to give me all the list of the things that had to be accomplished, so do whatever intervention. And okay, and therefore, how is it possible that you are in this unit? And sometimes it seems that we're in the beach. That's why you should have that they dropped the intensity of the light. This would be my intervention. Let's reduce the light. Let's reduce the volume. And the sound volume. They even had a radio on, and therefore I can say, tell everybody to go to listen to the music outside. We can't do that, because the ones that are at night plays the radio full volume, because if not, they fall asleep. Well, things need to change. Things need to change, and our interventions need to be able to be seen, need to play an effect in these kinds of babies. And another thing, it's the positioning of a premature baby. And this is what I was telling you. Why, if the baby is complaining in the interview that we're doing, if the baby is complaining because the baby feels uncomfortable, I always tell the nurses, hey, we should see, and we should listen for the premature baby. And please, you stay in a bad position for a long period, and let's see, but you can move. And that's why everybody that's here today, and right now, if I feel uncomfortable, and, and therefore, but the premature baby can't, and that's why. And therefore they can't fight against the force of gravity, that it's the big enemy of the premature baby, and that's why I cannot accommodate as you leave me. And therefore right now, and therefore when that baby, and we can find that flat head, we can, because nobody moved it, nobody moved it, and nobody think that, and therefore with and therefore one can say one cannot move it, one cannot touch it. I cannot touch it, and therefore what they can do, the minimum that they can do is be comfortable. And therefore we can say that some of the doctors, I say I'm not going to bother him, because I'm not going to do it alone. I'm not going to do it. I'm going to do it with someone, but I'm going to do it with such kindness that the baby it's not going to be able to notice that I moved him. And I think that a big part of the neuroprotection of our babies, it's that we start to change and to be more human in our treatment. Because now I want to ask you, all of you that work in different units, do you think it's very hard? And you think that it's hard to take care of the neurodevelopment of a premature baby in a unit? Do you think that it's a lot? Because most of our in the hospitals in Latam, the problems that we have, it's the budget, it's not enough. And therefore, do you think that it takes a lot? Do you think no, it's not expensive? Mm. And therefore, and I want to tell you that we need to educate, we need to train people, and I want to tell you that I was working in the unit, and we used the Likert scale to be able to see the adequate positioning, and suddenly the lady that does the cleaning gets close and say, hey lady, ma'am, this baby needs to be changed, the position of this baby needs to be moved. And why do you say that we need to move him? Look, and leave. And he left. She left at the mob, and she says, come and see. And here it says that the baby needs to be like folded and tucked, but look, this baby is outside. You are right. Thank you so much. Thank you so much for doing this correction. And that's why. And then we did the correct placement. Imagine how big help would have been if the mother is inside. Who better than them to take care of the baby? And that's why thank you so much. And I hope to have been able, and I do hope that everybody that it's on the neonatal unit can care of the premature babies. Tomorrow when you go back to your work, you go doing that change, because we don't need a big budget. What we say, it's the changes in policies, but I think that the main change is over here. It's over here. And what do we need to be able to change and to protect the premature? We need our brain, and we need our hands. Thank you so much. And thank you so much, Dr. Yvonne. And and that's a huge teaching, really, the management of pain and stress of the babies, because we do know what it feels. Many years ago, if all those issues were made invisible in neonates, and of course, there's a lot to do. and um, and therefore we're going to continue with Dr. Luz Vaquero, that she's online, and she's also going to talk about the transition process. Dr. Yvonne talked about some measures for stress positioning, and now we're going to listen to Dr. Luz Vaquero. She has the floor. Can you hear me well? Well, first of all, I would like to thank you for the invitation. It's an honor for me to be here sharing this space with you. And going back to what Dr. Yvonne was mentioning, it's that when we welcome a neonate in the NICU, what first thing that we need to do is stabilization, and care should be family centered. We need to reduce the level of physical pain and stress because we know that the baby has a lot of devices connected. The light, sometimes it's too much, and that's why there is a stress. There's a sensorial overload without leaving aside the hemodynamic stabilization, the respiratory and the stabilization at all levels. It's very important that there is communication amongst all the members of the team. Right now, I'm not in neonatology. I lived for 40 years I'm currently in Bogota, and for last 10 years, I've only working with babies and with school-age children. However, I've spent 15 years in the neonatology service of the Domingo Luciani in Caracas, and also in the Hospital Clínico Universitario, to whom I pay an homage. And one of the most important thing is that we need to be work as a team, not only with the nurses that spend so much time in doing their job, but also with the parents. I believe a lot in informing the parents. I think we can we can work on time optimizations. Then the parents can spend times in NICU when they change the diaper, when the mother is breastfeeding, and we can do this to do the stimulation without elevating the cardiac output or the energy output. We can suggest that whilst there's a change in diapers with a cotton to stimulate the skin of the baby, and then that they can caress him, because the skin to skin beyond the kangaroo program, it's very important and gives them that it reduces the stress that they don't have in the NICU. On the other hand, and we can listen. We need to create a microenvironment and the microenvironment, because the idea is to protect the neurodevelopment and avoiding that sensorial overload. And that's why if it and if not, I just want to talk about the adequate positioning. And because they do the contention of the baby as if the baby were still in the womb, and that reduces the stress, and it also changes. And one of the things that I wanted, we can say that in the last picture, we can see that one of the most important things that I want to cover in this space is that many times many babies, because of their physical condition and because of their neurologics, or because of the perinatal conditions, um, and they require Dr. Luz. Can we please? We are having issues, and can you check your mic, please? Apparently, Dr. Luz is disconnected. I would like to welcome Dr. Alvaro. And therefore, whilst we can reestablish our connection with Dr. Luz, and we're going to continue this discussion about this motor process and the transition to home. Okay, thank you so much. Sometimes we talk about interventions in the in the NICU, but as a part of, I had to talk about the transition to home and the moment and when we do an early intervention of all the early care programs, and sometimes sometimes they spend much time or less time. Sometimes there's more neurological risk, sometimes there's less neurological risk, but all of them should go through standardized follow-up programs that have some stable minimal parameters that we know they're difficult to manage the different contexts, because each context has a different reality. They start from a different kind of situation, but that we as professionals in the neonatological, pediatric, and also in early care, we should push forward, because so that these standards help us to create reproducible processes that can be measured and that can allow us to use as tools that allow us to identify when are we going to have a higher neurological risk and when are we going to have, but we need very specific tools that are adapted to the context. Many times we wanted to extrapolate realities that can be different. In the case of the Spanish context as the US, we would like to implement those programs with all those tools, and we do need them to be specifics. We need to have it specific. We need to study these tools in our populations in Colombia, in Mexico, in Ecuador, in Argentina. We need to ensure that the percentiles and that the normative measurements of the population are specific for us. And this is something that doesn't take away the standardization, because it doesn't reduce the value of the experience of the professionals in early care. No, it gives them some support. It gives us a guarantee that regardless of where the baby is born, either if it's in a more rural context or if it's in a big city or in a smaller city, there it's a minimum, and there is a process that ensures that not everything depends on of who's holding the baby or who takes care of the baby, if it has more or less experience, but it all depends that we need the same kinds of circuit tools and process that ensure and early monitoring. And this can only be possible when we ensure the quality in the assessment and all the process that we follow up and allow the professionals to be trained in all these kinds of tools and going to conferences like this one in ACELPNEO that allow us to be updated in that the quality for and that the updating it's something that needs to be done, and that's why early care as because it's inclusive, and if it doesn't get to those rural environments, if it doesn't get to those populations that don't speak the dominant language, that they can have, that could endure social risk, socioeconomic risk, early care, if it's not inclusive, it won't help out. And therefore, in the intervention strategies, let's go to the second part of the presentation. And therefore, we also talked about this. We can see the early detection program. And therefore, if we don't open up the door to a very specific to the mother, and that goes in, and also in the natural, and it's not very important, because sometimes we can use the best detection programs, we can use the best tools available for the detection of the high risk, but it doesn't change the way that we intervene if it doesn't has to be based in what the evidence in the scientific literature tells us, that it's the processes on which have to bet on well. It's not. It doesn't. Very important. I'm a physiotherapist, and in my field, we've had a constant struggle regarding the methodologies. I think that now we've been able to seek that perfect recipe. We have fought for this such or such a recipe, and one lacked something, one was missing. Some didn't work, and what evidence tells us, and where we are heading, and what we are betting regarding the implementation. And when we have experiences in Colombia and all over the world, we can see that. we can see that the secret it's not in the recipe but in the tools, and we know what are the tools that best work to accompany the families. These are focused in the natural environments, but because the question shouldn't be what methodology do you use, it should be um, and therefore interventions that are based on functional goals and what happens on a daily days, and the reality of what we need to be able to work, and the needs that this family has in this different context of what happens at the grandma's house. So this is where we need to work as early care professionals when we're working on a specific tasks like eating, playing, sleeping, go to school. This is this is where the focus should have a higher impact, and the enriching, the environmental enrichment. And we can see that it's going to be, we're going to have super stimulating, we're going to have swings, we have hydrotherapy. So we have so many things that can have they can have a certain level of evidence that are significant. We have betted on that, but if we really want very well clinics with a lot of stimulation, but this doesn't match with and therefore, and we do know, especially in animal models, that they don't have a lot of impact in the natural environment, and then reach that has to be 24/7, and therefore we 3 hours, 2 hours. It doesn't have it doesn't have a significant impact in the life of the baby or the mother, because we are not going to be able to reach those functional outcomes. Then, since the topic of coaching to increase the family capabilities, we and as we can see the development care within the NICU. We can see that all the interventions that are focused and that place the family at the center of the intervention, and has to be a guideline for early care. We cannot see that we have some wonderful interventions in the NICU that have the family, that train the family to a process in which, after a waiting list, in some cases, a long waiting list, they depend from the professionals' early care. It's just for a couple of years in the life of the babies, a couple of years in the life of the family, and we needed to increase the capabilities of the family so that and so they can be able to get empowered as a way to be able to offer an opportunity and to build a future that it's based on a day by day, on the family, on friends, on having fun in the future, which is where we have to focus. We need to focus in the future. On the other hand, and all of this is within an inclusion and standardization process. That's why it's very important. We need to focus on that collaborative work. And as Yvonne will said, this is something that we cannot done just based on physiotherapy or occupational therapy. We need to do a multidisciplinary coordination, which is one of the most wonderful things that this conference has, which is the diverse clinical reality that many times, and this is what happens in the literature, this is a barrier, and it acts as a barrier. We can see that the difficulties that we have for communications amongst the different professional roles, we can see that the communications that we have, so when the family leaves the NICU, it's not lost in a labyrinth, and where some things depend from education, some things different from health, some things depend on social development. That intersectionality in early care and that multidisciplinary care amongst professionals, it's critical. And the goals are not just of occupational therapy, of physiotherapy, or neonatology. No, it's the goals of the need and of the family, and that's why we need to work together, where the family is not just something that we accompany, but as Yvonne in Loosewell said, that the family, it's at the center and it's a part of the team. And I think that you've said very important things, and And we can say how there are positive stimuli that sometimes we as healthcare professionals don't have. That's why we need to allow positive stimuli in in babies since an early stage, allow for neuromotor development. I'm going to give the floor for Dr. Luz, and I have a question for for the group. And what are the main risk factors for motor development disorders in neonates? Dr. Luz. And I wanted to apologize because of the audio issues. I was telling you that it's very important to train parents. It's very important to train parents when the mother is going to change the diaper of the baby, or it's very important to teach them how to do skin stimulation with no big mobilization at the moment of the kangaroo program, where they have the baby on their chest. We can tell them for them to sway them softly. In this way, we're doing a vestibular stimulation. Why am I saying this? I was saying that some babies that need oxygen therapy, of course, in phototherapy, need their eyes covered either by the nurse or the physician or whoever has to do it. And in my professional experience, I've welcomed a lot of babies with retina tear because the eye cover was not well. That's why we needed to teach the parents about what we can get from the sensorial system without having energetic or beyond what it's necessary, and to be able to prepare them for discharge so that they can have a very structured program, especially physical contact. It's important that it's my contribution, because when we have a baby, that it's not, and I'm talking about responsibility of stuff, but when the baby's not, but when the baby gets blind in NICU or other pathologies that they didn't have a birth, it's harder. And when we talk about the neuromotor area, as we can say, it's very important to have, and therefore to be able to include this. But I defend physical contact, which I think it's very important. Thank you. I just want to make a comment. I just want to make a comment about the question, that I think that it's a very important, and I think that it's one of the main focus, especially within the follow-up of a population with a high neurological risk. And I would like to make a call about the standardization that we need, the standardization in the early detection programs, to be able to place in a specific focus in the population that is not going to go through the NICU. Because if we talk about cerebral palsy, that it's almost 50% of the babies that after a complex birth with prenatal risk factors, but that are going to go home. And the trend for these kids needs much more conservative. They need to reintegrate, and they need to be referred to specialists. These babies need a community follow-up. They need an increase of community capabilities. We need programs that detect prenatal risk that could be important for the development of cerebral palsy, and that sometimes we cannot do it from the NICU, but we can also check out those primary care settings. We have to help them to have better tools for the neuromotor detection, that they have better things for all the difficulties that we know that these types of follow-up with all the time challenges. But we do have literature, we do have tools to be able to do it, and this is something that it's vital if we need which if we need to cover this population, which is high. I don't know if we have some question from the audience.
Thank you very much. Wonderful panel. It's an interdisciplinary panel, very important one. I have a comment and a question. As you well know, Al CEPNEO doesn't speak only about the preterm monitoring and also the care of preterm babies. We believe in the UCIN follow-up, meaning an ICU follow-up. The babies should be in the NICU and continue in the follow-up. But furthermore, that these type of care should be oriented, or at least the initial evaluation, and afterwards the control to the high risk babies, because a baby has been through a surgery is really having a lot of problems due to intubation, parenteral feeding, among other things. So I would like to ask you the following question. How do you see the evaluation of these babies and the interdisciplinary work to be able to prevent the appearance of muscular contractions and other problems? Thank you very much. Yes, the physiotherapist doesn't only take care of the preterm babies, but we take care of all the neonatal babies who are sick in an NICU. It could be due to preterm babies or because one type of disease, surgery, pathology has the need to be in the NICU during the first months of his life. And afterwards, the importance of to work in as a team. That's why the team is fundamental. There are not many neonatal physiotherapists, and we detect from the early onset babies who we don't know about anything. We receive a lot of babies that we don't know anything about these babies. So we started to research, and if that baby is referred from an hospital that has shared all the clinical data, it's important. So it's a very easy baby to work with, but we need to investigate. It happens in Guatemala with the sectors in the provinces, indigenous areas, and they cannot be able to explain what happened with the baby. So you try to take all the information about the baby, all the clinical data of the baby to try to do the due assessment and to do a good treatment. What we work with the NICU babies, that's a different story. Thank you very much.
Buenos días.
Good morning.
Bueno, en la conferencia
Alvaro, in the
mencionado
conference you mentioned some ingredients
que son
which are
más
part of the menu.
específicos para un
Some
enfoque
are
de
much more important than other techniques and
en la intervención
methodologies
temprana
in
y
the early
de
intervention with high-risk babies.
si ya está tan claro
If
que los
it's very
principios
clear
y
that
el
there are some
curso de la
principles
convivencia se
and the
siguen
scientific
como
evidence
basan en la
shows
teoría de los
that
ingredientes
these
de
must be
las
the ingredients of the
intervenciones,
interventions,
mi
my
pregunta
question
sería, no sé
is,
si es fácil de
I'm not
responder,
sure if
pero
it's easy
me
to
gustaría que
answer,
usted
but I would
como
like
nos
to
comentara
listen to
por
your
qué es tan
comments.
difícil
Why is it so
poder
difficult
hacer cambios y hacer nuevas
to go
intervenciones
towards these new
basadas en
intervention
evidencia, basadas
science-based,
en
and
principios que
based on
sabemos que
principles
funcionan,
that we
que
know
seguimos
work,
tan
and we
aferrados a viejas
continue
prácticas y
with old
metodologías
practices and
que la evidencia
methodologies, and the
demuestra
evidence
no son tan
shows
buenas,
that
por
are not
ejemplo,
as good.
parálisis cerebral
In cerebral
específicamente,
palsy, for
hay
example,
evidencia
there
ya
is
suficiente
clear
para decir que
evidence
estas
to show
pocas
that
son
some are
recomendadas.
not even
Y sin
recommended.
embargo, bajo esos
Nevertheless,
principios,
under these
seguimos
principles, we
manejando muchos
continue
de los niños a
to
quienes debemos hacer
manage and to take care of
intervenciones
many
tempranas.
of the babies that we need to do an early intervention. A very difficult question. This is my own opinion, but I do think that there is a part of the tradition regarding the use of methodologies. Methodologies that are based on learning, methodologies, control, motor control, that did not take into account that are, for example, the natural surroundings, the participation of the families, and are used
in practice today. But maybe that trust in these recipes and methodologies that slowly are shifting in the academia or in the university still really strongly binding with the context in, like in Spain's, the one that I know the most. And still in the universities, in our case, pediatric physiotherapy and neonatology based specifically in specific methodologies. I think this is very hard for us, and it's continued to be very hard to do that transition towards the new methods. It's a mind shift. It needs really a clinical mind shift. Has to do a lot with the attitude of the professionals. And based on my personal experience, we need to feel much more safe with the application of techniques and different methodologies when transition in our professions has evolved in the past 20 years towards a healthcare profession with its confidence, clinical reasoning, and it has to be based in these ingredients. What we are seeing right now is always also a natural transition, the appearance of many methodologies that use these ingredients that we know very well in natural resources, the families, the environment, a rich environment, and that gives us the feeling of a methodology per se. It has very good outcomes, but it has a component, and was already mentioned that, which is education, training, to need level A, C, BC courses for methodology that will not present better results than the others because the ingredients are the same. So we have a framework that we that's international classification. We have a framework given by all the associations that are enough to be able to guide that reasoning of the professional towards something that's natural, simple, which is to sit down with the family, what the family needs, and from our point of view can support them. This is a very difficult shift. It's a change that will need time, but the research is building on a daily basis with new publications that talk about the programs, that active motor training is very important, that we need to obtain or therapies based on many aspects. But it's difficult, I know, but we can jointly arrive to that level and helping and supporting professionals that due to the young people or the older professionals, we need to train them. So we need to work jointly. But I am positive about that. Yes, I think that all of us here have faced a certain moment. This is how we've done that in the past. It has given us very good results. But this is the worst enemy that we are facing. And when you say to somebody, oh, you can see the scientific evidence that is showing that we need to go through another path. So they feel that they are being attacked. No, I do this. This is how I work, and this and that. So you're not going to change the way I work. So it's very difficult. We need to say if it gives you good outcomes, very well. But currently, there are new techniques, new interventions that will give you better outcomes. As Alvaro says, the old keys don't open new doors. So there are new ways to deal with new interventions. I always say that there are techniques, interventions that were born in the past century when there was no early intervention, when no was neonatal intervention. We saw the birth of these interventions, and the majority of the doctors are deceased now without being able to update the techniques. So it's very important to update all the techniques. And what Alvaro said, to learn on a daily basis, to train ourselves, because the changes are based on the university programs. The university programs, once we arrived as professors in the university, they give us programs from the past century. Many of the interventions that are not even being used. They're dated from 2014, 2015. They're out of the usage in the neonatal units. But the universities is what they are teaching. So we need a lot of investigation, research, study, and updating. Okay, thank you very much. I'm Andrea from Chile. Thank you very much for this very rich talk. In Chile, Chile did a research in Maule region, which is Central South region, where I asked the nurses what they knew about the neurodevelopment. And talking about the cross-cutting discipline and to how to promote the education in neonatal units, I discovered that the nurses knew, but the technicians in nursing didn't know what was that. So inside that area, as you already mentioned, all the interventions related to pain and are a lot, and that awareness is still lacking. So we know that the 60s, the newborn babies didn't have any pain. So we found out it's a huge barrier related to how do we value the pain, and what are the strategies out there based on the experience. Have you seen those same barriers? What are the strategies that you've had in that sense? I think we are all aligned, but we have good results in educating our nurses. In Guatemala, there's still a lot of scrub nurses, assistant nurses, and I think they take over these babies, yes, in countries like mine, in Guatemala. Large part of the work is done by the assistant nurse. So what do we have to do? Teach them. In fact, one of the logos of neonatal therapy is 100 reasons to share knowledge, and you cannot put any one of those in the cupboard. That's what we need to do. This is one of the objectives of the neonatal physiotherapist. We need to educate. We need to take our teachings everywhere. And sometimes the best strategy is to teach the mother, the father, because they are going to take care of the baby. I have a case, and we use the therapeutical bottles. We see if the baby is able to suck for 6 ml, 3 ml. And sometimes the parents say to me, he doesn't like that bottle. He prefers yours. So they don't like also the parental feeding. So this is very important to teach the parents. And this bottle, I show them, this is a secure flow because the baby has the capacity to have 3 ml in his mouth and don't have any problems. So the idea is to take care of that. So it's part of the strategies to educate the people and also the family. That's why they need to be there as well. Thank you very much. Okay, Yvonne, you have 1 minute to wrap up the session. Thank you. Okay, just to add what Yvonne and Alvaro mentioned regarding sharing the knowledge without considering the status of the profession. I think those who are updated, who are reading, studying all the time, with all the clinical reasoning, we need to seek these spaces to share with others, to have a cup of coffee and talk about the advances and technique changes. And step by step, we were able to have that transition. And obviously, parents are the best physiotherapists who are going to really take care of their children. They need to learn new techniques. Thank you very much. Thank you very much. Thank you very much for all your questions. But we have 2 more days to share with the professor, so let's continue with the agenda. Thank you very much.